Hi, Doc.
Yeah, good evening.
Evening. Sorry about the delay. Forgive me.
Don't worry. Yeah, I thought I wasn't coming on, so I was even going to find somewhere.
Oh, no worry. Please come back.
Don't worry. So we are going to do the second part of the hemodynamic disorders. Let me share the slide. Okay, same with me. Let me share the slide.
Madam, your network.
Network is what? It's not stable.
And scratches.
You've turned into network surveyor.
Can you hear? But can you hear me?
Yes, Doc, we can hear you.
Is there background noise or it's okay?
A few background noises, but I mean it's manageable.
Manageable.
It's manageable.
Yeah, it is.
Okay, so we are going to talk about hemodynamic disorders. And today we'll talk about normal blood clotting, that's hemostasis. And then we'll also talk about thrombosis. Okay, so this is different from homeostasis. So homeostasis is the maintenance of a constant internal environment.
Okay.
But what we are talking about is hemostasis. That is the process of blood clotting, the physiologic process of blood clotting. The pathologic aspect of the same process is called thrombosis. Okay. So thrombosis is the formation of a blood clot from an injured blood vessel. Before a clot can form, you need three things. You need the vascular wall, you need platelets, and then you need the coagulation cascade. So for the process of clotting, when you have injury to the vascular endothelium, it causes platelets to adhere to each other, and then they form the platelet plug. Then subsequently, you have clotting factors aggregating at the site of the clot, and then they interact and form a stable clot. At the site of the injury, from this diagram, you can see that at the site of the injury, the endothelium is exposed, and that is where the platelets will be attracted to, the exposed endothelium, leading to the formation of the clot. So within minutes, the platelets would aggregate at that point, and that's called platelet aggregation. And then they will change in shape, and they release granules, which cause the formation of the clot. Now, the other thing is also that at the site of the injury, there's a protein release called tissue factor, which is what stimulates the clotting cascade or the clotting factors. You've done blood clotting in physiology.
No.
Have you treated blood clotting?
No.
Hey. This makes the pathology so difficult when you haven't done the basic things in physiology. Okay, so let me just summarize it. What I'm trying to say is that when you have an injury, there's an injury to the blood vessel wall. It exposes the wall of the blood vessel. It causes platelets aggregate. When the platelets aggregate, there's a release of tissue factor, which causes the clotting factors to also start the process of blood clotting. And this secondary process with the clotting factors is called secondary hemostasis. So the first stage where the platelets aggregate is called primary hemostasis. Okay. So The coagulation cascade needs the clotting factors. There are 12 clotting factors in all, and the clotting factors have two parts: the extrinsic pathway and the intrinsic pathway, and they meet at a common pathway, which is where factor 10 is activated. So when you go, just go and read on the clotting factor. So the factor 10 is a common pathway. Now, when factor 10 is activated, it activates factor 2, which is fibrinogen, which leads to the formation of the clot. Then later on, you have factor 13, which strengthens the clot and leads to the clot formation. And that is what actually prevents the blood from leaving, or it seals off the injury in the blood vessel. Okay, so for hemostasis not to go on unabated, because the clots can also be dangerous. Okay, so you need to have a system where that clot can be controlled. And so we have other things in the blood called antithrombin 3 and protein C and S, which would prevent excessive clot formation. Then we also have plasmin, which causes enzymatic breakdown of the excessive clot. It's activated by plasminogen. So it's like when you have the free radicals, you have antioxidants. So you have clotting factors, you have plasmin and plasminogen. So there are checks and balances so that the clot doesn't go on excessively. Like contrasting thrombosis and then things that inhibit thrombosis. So in nature, they are in a balance so that you don't have excessive thrombosis occurring, or you don't have excessive breakdown of the clot causing excessive bleeding. So all these things go on side by side. So let's look at thrombosis. So thrombosis is a pathologic tendency of the body to form clots. And for thrombosis to occur, we need three things. And that's called the Virchow's triad. We need endothelial injury, we need coagulability. So if you have a situation whereby there's injury to the blood vessel wall, it will promote formation of blood clots, even though there's injury. So there's no cut on the body, there's nothing. So let me give an example. People who have deep vein thrombosis, okay, they have that clot formation, but there's no cut on their body, and yet they have that. So it's a pathological process. And these are the three factors that will lead to that pathological process occurring. So what are some of the things that can cause endothelial injury? If you have a myocardial infarction, if you have inflammation of the valves, if you have atherosclerotic plaque in the artery, if you have inflammation of the blood vessel, all these can cause injury to the blood vessel and lead to thrombosis. Okay, so this is a thrombus in the left ventricular apex of the heart. And so you can see that small red blood clots formed there. And this has occurred because there's injury at that area, and that vascular injury would attract platelets. And so when the platelets settle there, it causes other clotting factors to come in and cause a clot there. So other things that can cause endothelial injury are bacteria, endotoxins, hypertension, turbulent flow over scarred valves. Okay. Other examples are radiation injury and excessive cholesterol, cigarette smoke. Okay. Now let's look at the second factor, which is stasis. So stasis just means that the blood is at a standstill, it's not flowing. And this would cause the blood to clot. And what are some of the circumstances in which you have stasis? So the same myocardial infarction, if you have an aneurysm, that is abnormal dilatation of the blood vessel, there can be stasis there. Or a patient who travels for a long time sitting at one place, the blood pooling in the legs, you can have stasis as well. Or in a patient with, because there's dehydration, that can also lead to stasis. Then the last factor is hypercoagulability. It seems my internet connection is unstable. Please let me go up. Jude, 1 minute. Let me go up. I think it's better when it's upstairs. Okay, so coagulability means that the blood has an increased tendency to clot. And this can be divided into two. We can have primary and secondary disorders. So primary disorders means that the person is born with a genetic disorder that causes their blood to clot. So things like clotting factor deficiency, mutation of some of the clotting factors, or deficiency of the antithrombotic factors, so like antithrombin 3 and lack of protein C and S. So I have a list of things that are associated with an increased risk of thrombosis. And you can see that oral contraceptive use, smoking, prolonged bed rest, they are all increased risk of thrombosis. So morphologically, the clots can form anywhere. It can form within the arteries, the veins, the capillaries, within the heart. And what you realize is that when the clot forms and it is propagated from its main source, once it flows in the blood vessel, it's an embolus. So what this means is that you have a blood clot formed. It's sitting somewhere in the blood circulation. When this blood clot becomes mobile, then it's called an embolus. Okay, so the embolus can go and block any part of the body, and then that can cause ischemia. When you look at the clot, let's say if you take the clot and you cut it into two, you would have concentric rings, which are called the lines of Zahn. And what it is that at the core, you have platelets. Then you have concentric rings of clots, and then younger clots, and that gives it different colors. And so you see that lamination within the body of the clot if you take a cross section of it. Now, what are the things that can happen to the thrombus or the clot which has formed? So there are several fates that can occur. It can undergo propagation. That means that it becomes bigger and bigger and bigger, and so eventually it blocks the blood vessel. It can also undergo embolization, meaning that it detaches itself and then becomes mobile in the blood. Or it can undergo dissolution, whereby the clot busters in the body would dissolve the clot naturally by fibrinolytic activity. Or it can undergo fibrosis, which is a process whereby you have fibrous tissue forming within the clot, and then the clot becomes recanalized. Okay, so this is a pictorial form of what I was saying. So you have the thrombosis, the blood clot which has formed. It can resolve such that it is dissolved completely by antifibrinolytics, or it can undergo embolization, whereby it becomes mobile and can go to any organ, for example, the lungs. Or it can become organized into the blood vessel wall. So it becomes incorporated into the wall, or after the organization, it becomes recanalized. So you can completely block the blood vessel, but later on a channel can be created as a result of fibrinolytic activity. Okay, so we have several types of clots. We have venous thrombosis, which forms in the veins of the legs. Then we also have deep vein thrombosis, which forms in the large veins of the lower limb. This is the one that can embolize to the lungs, and typically this one causes sudden death because it becomes a pulmonary embolism, which will travel to the lungs and cause death by occluding the blood vessels in the lungs. Okay. So apart from thrombosis, you can also have a phenomenon called disseminated intravascular coagulation. So to explain this, what happens is that something triggers blood clot formation, and it becomes a generalized phenomenon in the entire body. Now, when the blood clot formation is triggered, it mobilizes all the platelets, all the coagulation factors in the body, such that all the coagulation factors become used up. So eventually what will happen is that the blood will not be able to clot. So if you have a patient who develops disseminated intravascular coagulation, or DIC, such a patient, you try setting an IB line and you realize that the patient will be bleeding excessively. Okay, so these are some of the things that can occur. So what are the things that can trigger the DIC? You can have things like bacteria, toxins, severe infection, amniotic fluid, which can trigger the DIC and cause excessive bleeding. Okay. I want us to look at embolization. So an embolus is a detached intravascular clot, and it can either be a solid, liquid, or gaseous mass that is carried by the blood to a site separate from its point of origin. And about 99% of them are from a blood clot which has formed, so thromboembolism. So several examples abound. You can have air embolism from nitrogen gas, for example, or you can have fat embolism, atherosclerotic embolism, that's cholesterol emboli. So usually what we say is that, or what we know is that an embolus is thrombotic in origin. What it means is that it came from a blood clot which was stuck in a blood vessel and then became mobile. So usually that is what it is. And pulmonary embolism is the commonest complication of embolization. And usually it occurs in a situation whereby the blood clots formed in the deep veins of the leg. As you move, as you walk, it becomes mobile, and then it is transported to the heart. The heart will pump that blood with the clots in it to the lungs. And because the lungs have tiny, tiny blood vessels, the embolus will go and get stuck in one of the tiny blood vessels in the lungs. And depending on where it gets stuck, you can actually have death occurring because it blocks the lungs. And a situation whereby you cannot oxygenate the blood. So this is a picture of a patient who died from a saddle embolus. You can see that this is a section through the blood vessel, and you can see this big clot, which is something like a V shape. This big artery is actually the pulmonary vein, and the clot is sitting in there and has blocked both points of entry into the lungs. So this patient actually died. So this is a pathological specimen. Okay. So yes, it can cause sudden death or right ventricular failure. Then you can also have systemic thromboembolism, whereby the blood clot goes to any part of the body, any part of the body at all. So they come from atherosclerotic plaques, aneurysms, and so on. And the major sites are the lower limbs. So 75% will end up in the lower limbs. 10% will end up in the brain. That can cause a stroke. You can also have some of the emboli ending up in the intestines, the kidney, and then the spleen. So the extent of the embolization depends on if there are other blood vessels in the area. So if you have a situation whereby you have other blood vessels in the area, then other channels are available for supply of oxygen. And then if the vessel caliber is big, then it causes more damage. And then if the tissue has an increased vulnerability to ischemia, then it's also prone to damage from the embolism. So let's look at fat embolism. So in fat embolism, it is fat globules which are found in the circulation. And usually this comes from fracture. When you have a fracture, typically fracture of the long bones, you have fat embedded in the marrow. So when there's fracture, some of the fat from the marrow can escape because there's a break in the continuity of the bone. So it can escape into the blood vessel and have an emboli, which is floating around, can get to the lungs and also lead to sudden death. Okay, so if it goes to the brain, it can also cause neurologic symptoms, and it can go to the lung and cause pulmonary insufficiency. So if you have a patient who has a fracture and suddenly has difficulty breathing or becomes confused and has neurologic symptoms, you should think of fat embolism. Okay, so this is a bone marrow embolus in the pulmonary circulation. We can also have air embolism. Air embolism usually occurs when you have nitrogen gas dissolved in the blood. This usually occurs in deep sea divers. So for deep sea divers, they usually have a reserve of oxygen. When they dive into the deep sea, because of the pressure difference between where they are and where they came from, you can have some of the air being dissolved in the blood, and that can lead to embolism occurring. Usually when there's a sudden change in pressure from when they dive and the diving is too sudden, it can lead to a sudden change in pressure, and you have gas bubbles within the circulation, which can obstruct blood vessels. And then we also have a certain type of embolism called amniotic fluid embolism. This is a very serious kind of embolism, and usually it is fatal, and it complicates labor and the immediate postpartum period. We know that the amniotic fluid is around the fetus, and so during labor, when there's delivery, the extreme force generated during pushing can lead to rupture of the uterine artery, and this would cause some of the amniotic fluid to enter the circulation, and it enters the circulation as an embolus. So you can have a history of a woman who delivered and then suddenly has difficulty breathing, becomes cyanosed, and can even have seizures and a coma. This sometimes leads to sudden death. If the patient survives, they usually have a pulmonary collapse. They can also develop disseminated intravascular coagulation. The underlying cause, like I said, is the infusion of the amniotic fluid into the maternal circulation. And usually this can occur when there's a tear in the placental membrane, following rupture of the uterine veins, uterine vessels. Okay. So when you look at the amniotic fluid emboli, you find fetal material, fetal skin cells, lanugo hair, fat, mucin from the fetal respiratory tract, all as part of the clot. And this is what, saying that this is what leads to the excessive what am I even trying to say? So these products are the ones that will trigger the respiratory distress and all that if they end up in the lungs or in the pulmonary circulation. Then the patients will end up with respiratory distress. Depending on how much of the lung they block, you can end up with sudden death. Okay. Please, are there any questions? The thrombosis organization is a yes.
Please, with the embolism,
Mm-hmm.
can it occur in smokers? Like those who smoke?
No.
Okay.
Because when you smoke, the smoke goes into your respiratory system. When you smoke, the smoke goes into the respiratory system. It doesn't go into the blood. But what the smoke can do, the smoke can cause the debris into what you inhale. It goes into your respiratory system. It gets dissolved into your blood. Now, the tar and the other things can cause damage to the blood vessel wall.
So, with when the woman is going to deliver and she ends up getting a high blood pressure, is it due to embolism?
No, it is due to eclampsia. It's due to eclampsia, not embolism.
Okay.
The embolism usually causes sudden onset of respiratory distress and cyanosis.
Okay. Thank you.
All right.
Mister, I have a question.
Yes, please go ahead.
Hello.
Normally, what we do at the ward is that when they set line and the line gets blocked, we draw a normal cell line and then we flush.
Mm-hmm.
We flush the either the clot or we flush it, and later you realize that the this thing become patent. So, assuming there is a clot and then we flush, what will happen?
So the clot will go into the circulation, but it's a very tiny clot, so it's not likely to cause any problems.
Okay.
So, madam, is it advisable to do that?
Well, you can do that, but what you should do, what is actually advisable to do, is to try and draw out the clot. So
But they push it
rather than push. But what I'm trying to say is that the amount that you push is not the clot that goes into the blood is a very tiny clot.
Okay.
And usually the anti-clotting mechanisms in the body will dissolve it and it shouldn't cause any problems. I hope you get me.
Yes, please.
Madam, my question is two. Now, with what Auntie Mabel just asked, how do you draw a clot out? Secondly, the second question is, what has vitamin K? What is the relation with vitamin K and blood clotting or blood thinning?
Okay, so you put a syringe in the cannula and then you draw. It's like you're suctioning. So once you draw, you keep drawing and drawing, and you see that the clots will come, will be drawn out. So if you provide a suction, once you draw, the clot will come. But sometimes it's easier to push than to draw. Because if it's a stubborn clot and it's difficult to dislodge, it will not. It's rather easier.
It will cause pain.
Okay. Vitamin K is needed by the liver to form clotting factors. And so you need vitamin K to clot the blood. So if you have a situation whereby there's excessive bleeding, you give vitamin K and it helps, and the patient stops the bleeding. So vitamin K is good for clotting, not for thinning blood.
Okay. And madam, one thing too. You see, with most vitamin Ds, they love to administer it with K supplement. They always add K to it, and they call it calcification. It helps allocate calcium to the right channel. My question is, if vitamin K helps the liver to do the clotting factors or contribute to the clotting factors, what does the K2 has to do with calcium or too much calcium in the blood?
So
that can lead to
So calcium is one of the agents which help with the clotting. That's why I was saying, go and look at the clotting cascade. When you look at the clotting cascade, it's a series of enzymes. It's actually very simple. 12 clotting factors. It starts from factor 12. Factor 12 is activated by factor 11. And calcium is one of the enzymes, one of the cofactors that is required for the enzyme activation. So you need calcium for that clotting cascade to function. You understand? So you need calcium, you also need vitamin K for clotting to occur.
Okay.
And madam, my next question is, when you have embolism at the heart, maybe a place, how is that one removed that is blocking, that can cause, what's the name? A blockade at the heart. How is it that one pushed out? How can it be flushed out?
Enzymes, like if somebody gets a heart attack, it means there's a blood clot in the heart, which is causing infection, is stopping blood supply to a part of the heart. That's why the person gets a heart attack. So there's an enzyme called streptokinase, which can be injected into the bloodstream to cause breakdown of the clots. We also have other things like heparin, which heparin is given artificially as an injection to help break down clots in the circulation. So that's how we deal with blood clots which are formed pathologically.
Okay, thank you, madam.
Please, I have another question.
Yes, please go on.
Please, you can see that when some women become pregnant, they develop various causes. And can that help? Yeah, can that cause any embolus when they are going to deliver?
Okay, so the varicose veins, it means that the blood flow is very sluggish.
Okay.
And so if there's injury to the blood vessel as well, then it will lead to a blood clot formation. I said that before you can have a clot formed pathologically, you need three things. You need vascular stasis, you need injury to the endothelium, and then you need hypercoagulability. So if you have a situation whereby you have stasis, which is what occurs in the varicose veins, the blood sort of sits there in the enlarged veins. So that is stasis. But there is no injury to the endothelium, and there isn't hypercoagulability. So you may not necessarily get clot formation.
Okay. Thank you
So
very much.
you need these three things to interact before you can get a clot being formed pathologically.
DJ, you have a question?
Is there another question?
Yes, I have a question. Doc, so I want to know if blood thinners are the best option when someone has an injury or a fracture. Must the blood thinners be given to the patient as the first line of action? I mean, when you have done all the stuff that is very necessary, but now the patient is stabilized, but so you have to start with blood thinners, or
no, I don't understand why you give blood thinners for a fracture.
Like, what I mean is, you said that when there is a break in the continuity of the bone, it can cause a clot formation. So
heart embolism.
Embolism. So I want to know that if you have a patient who has suffered from fracture and you have done all the necessary stuff to do with the fracture, will your next line of action be like, must you serve the patient the blood thinner to prevent the patient?
No, you don't give blood thinners as a prevention. You give it for treatment unless the patient has a condition that predisposes them to having clot formation, because it isn't a must that once you have a fracture you will have fat embolism. I hope you get what I'm saying.
Yes.
Yes. So since it isn't a must that everybody with a fracture will get fat embolism. You don't have to put everybody with a fracture on blood thinners.
Okay. Okay, thank you.
All right.
Is there any reversal for varicose vein? Any remedy?
So yes, surgically there is. But I would rather not go for surgery. We have less than a minute.